Respected chairpersons, ladies and gentlemen, at the outset I'd like to apologize on behalf of Dr. Chandra who couldn't be here because of some personal reasons. My name is Dr. Sumit Sethi and I'll be presenting this case of an IVC chronic total occlusion. This was a young 24-year-old female from Afghanistan who presented with swelling of the feet, abdominal pain and dilated vessels over the abdomen for last 2 years. She was a non-vegetarian and non-alcoholic with no past history of oral contraceptive use. On clinical examination, patient had a normal body mass index. There was mild bilateral pitting pedal edema. There was no icterus, pallor, clubbing or any lymphadenopathy. She had a mild liver enlargement clinically and a very large splenomegaly. There was no free fluid in the abdomen. On examination, one could see that she had very prominent collaterals over the anterior abdominal wall. She was investigated, found to have a slightly lowish hemoglobin of 10.9. Bilirubin was high, 2.2 with a direct of 0.6. Enzymes, the liver enzymes were not markedly raised. Proteins were normal. And the INR was 1.40 and she was HPS-AG non-reactive. She underwent a UGI endoscopy because of the dilated veins over the abdominal wall, and one could see that she had almost grade 2 and grade 3 esophageal varices. So all are suggesting a diagnosis of portal hypertension. She was subsequently advised for an MRI abdomen and an MR angiogram which showed a dilated infrahepatic IVC. There was a focal stenosis oblique of web in the suprahepatic inferior vena cava, and there were multiple collateral channels arising from the lumbar, intercostal and iliacus veins. The inferior right hepatic vein was draining normally into the IVC. Spleen was enlarged, as well as the splenic vein and the splenoportal axis were also prominent. There was some collaterals at the splenic hilum, and there was a well-defined but non-obstructing thrombus in the suprarenal IVC. This is the MRI which showed that there was a complete occlusion of the suprahepatic IVC, and one could see that there was a non-occlusive thrombus in the IVC at this point. On the IVC Doppler also one could see that there was a laminated clot in the subhepatic IVC at this stage. And also it revealed that there was a 4 centimeter total block at the IVC-RA junction. So we took her up for an interventional procedure to recanalize the chronic total occlusion of the IVC, as it was felt that she was going into irreversible portal hypertension. We took a right jugular venous and a right femoral simultaneous axis and did a venogram which confirmed that the IVC was totally blocked, a segment of about 3 to 4 centimeters. Then we tried to recanalize this clot from the femoral root by trying various wires like a straight tip 0.35 Teflon, the back end of an Amplard super stiff guide wire, and even the Brockenborough needle. But unfortunately none of these needles worked, or the guide wires worked. And at the same time we also used simultaneous echo guidance for assisting us in crossing the occlusion, so that because the angiogram was giving us a 2-dimensional picture and we were really not sure poking in there that we wouldn't have perforated the IVC. So we took an echo guidance which could actually show that we were still in the lumen and not hitting the sides of the IVC. This is actually the needle that we are trying and within the lumen of the IVC. Finally, we could cross this lesion with the back end of a 0.35 angled stiff type Teremo exchange length guide wire, and one could see that we have crossed into the RA with this wire. We then took a 4F multipurpose guiding catheter and threaded over this wire to create sort of a passage and go into the RA. And this this angiogram shows that we are into the RA, and when we inject contrast we know that we're in the right place. We then pre-dilated this lesion with an OptaPro 5x40 peripheral balloon at 10 millimeters, and then upgraded to a 1040 millimeter balloon at 14 atmospheres. That's the dilatation balloon. And one could see the lesion giving way with the pre-dilatation balloon. We could also, at the same time, we continued with the simultaneous echocardiographic guidance, which actually was of immense use in this case, and one could see even the inflated balloon within the IVC when we did the echo. The venogram after the balloon dilatation showed that we had sort of recanalized the IVC, and there was enough access for the stent to then cross over. So self-expanding barred stent was taken, 16 by 40 millimeters, and that was deployed across this occlusion. That's the stent being deployed. And then we post-dilated this stent with a Taishak 216 by 40 millimeter balloon at 10 atmospheres. But when we reached 10 atmosphere inflation pressures, the balloon just burst. One could see the horrifying sight of the balloon getting burst. And we were not sure at that time whether we had embolized this balloon into the circulation, which would have been really catastrophic. But luckily, the balloon was just retrieved in toto on the delivery catheter, and the pieces were intact. I mean, burst, but at least the pieces were there. So the end result showed a very excellent apposition of the stent with good flow across the IVC. The patient followed up after some time with us, and we realized that there was some partial regression of the collaterals. This is about 2 weeks later.
I think.
So I just.
Going on? Okay.
Just the final slide, the take-home message. Then, when faced with a challenging situation involving difficult to cross large vessel IVC occlusions where the risk of perforation is high, one could use simultaneous ultrasound and fluoroscopic guidance to plan interventions and then achieve a successful outcome. Thank you.